Okay, now let's talk about hygiene, which is chapter 40. And here are the objectives for this chapter, so you can see what we'll be focusing on. So, what do we know about personal hygiene? Well, it can affect or influence many different things, including the patient's comfort level, their safety, well being, and it's influenced by many different factors such as personal, social, financial, and even cultural factors. We have to use good communication skills when it comes to dealing with hygiene for our patients. And when we provide hygiene, we integrate other nursing activities. For example, completing personal hygiene for the patient or the patient completing the personal hygiene themselves, we can include a patient assessment, taking notice of different aspects of care and interventions. We always want to ensure that our patients feel safe, that they're comfortable, that we're promoting their independence and completing personal hygiene, and ensure their privacy and respect is honored. So once again, we apply many different pathophysiological aspects of knowledge when we provide hygiene care. So we have to recognize that different disease states create changes in skin, oral mucosa, and sensory organs. And a great example of this is for our patients that have diabetes, which can often lead to chronic vascular and skin changes, which impairs the healing of those body systems. In the early stages of acquired immunodeficiency syndrome or AIDS, fungal infections are often common within the oral cavity of our patients. Patients that have paralysis can also have limited blink reflex. They can run the risk of their corneas being dry and irritable. So we adapt our hygiene practices and care to minimize injury with certain conditions. The skin serves several protective functions, but also functions related to excretion, the regulation of body temperature, and sensation. And you know from your anatomy and physiology that the skin is consists of many layers, including the epidermis, the dermis, and the subcutaneous tissue. These all serve as a protective function for the skin. For example, we have to be cognizant that a weakening of the epidermis or that upper layer of the skin can cause injury to the patient if we, say, remove tape abruptly or we're not very careful in our turning and positioning techniques. We want to minimize any friction to avoid loss of skin, which can increase the risk for pressure injuries. And we also have to be cognizant of heat loss. For example, a patient lying in a wet bed or having their gown wet can contribute to heat loss. Let's take a look at our first patient. So we have Mrs. Winkler. She's a 58-year-old white woman recently admitted to an assisted living nursing facility. She has multiple chronic conditions, such as multiple sclerosis, which is a condition that affects the nervous system and ultimately the skeletal system, and diabetes. Plus, she has a history of coronary artery disease or a family history. Mrs. Winkler was married for 37 years, but her husband died suddenly 3 months ago of a heart attack. She has a supportive family with three daughters who live about an hour away from the facility. And she's very cognizant of the fact that she misses her daughters and her grandchildren because she relied on them greatly for her care, and she's used to seeing them every day, but she doesn't want to be a burden for them. Mrs. Winkler uses a wheelchair for mobility, but she's become progressively weaker with both her upper and lower extremities and is unable to push the chair herself and requires assistance with transferring. So, as you learn about all of this information on the patient, think about this question: what types of assistance might this patient need to participate in her own personal hygiene, and what we might do as a nurse to help her with her personal hygiene? So, our nursing student today is 20-year-old Jamie Johnson, and that nurse has been assigned to the nursing facility where Mrs. Winkler resides. She's single and works part time, so she does have some experience. And Jamie knows how important it is for patients to feel comfortable and to have their basic needs met. So, to provide basic hygiene, it's important that the nursing student know what is important for Mrs. Winkler's comfort. And when that hygiene needs are not fulfilled, the patient might experience complications such as oral lesions or infections. So, what should Jamie do first? What hygiene risk exists for Miss Winkler based upon the information that you know? Well, Jamie needs to review the effect of dependency on the patient's self esteem and to review ways to give patients opportunities to maintain self care. We want to preserve as much as possible Mrs. Winkler's independence and to ensure her privacy and to foster her well being. Mrs. Winkler is at risk for potential self care deficits, impaired skin integrity, impaired oral mucosa, and altered health maintenance. So during her hygiene care, Jamie interacts with Miss Winkler to assess her readiness to learn and to teach health promotion practices. So think about this question: what are some ways Jamie can help Mrs. Winkler maintain that independence? Now, as you've learned from your textbook in the lessons, there are many factors that influence hygiene, from a patient's social practices, their personal preferences, their body image, socioeconomic status, cultural variables, and health benefits and their own motivation. We also know that chronic illnesses such as cardiac, pulmonary, and neurological disease, cancer, dementia, and some mental illnesses can often exhaust and incapacitate patients in performing their own personal hygiene, or even if we are assisting them with that personal hygiene. For example, a patient can become very tired and short of breath, and they might need frequent breaks during personal hygiene. And we allow these periods of rest for those patients who tire easily. Patients can also be in pain because of illness or injury, and that limits their ability to tolerate hygiene and grooming activities or perform their own self care. Pain also frequently impairs range of motion, so the impaired use of the arms and hands or limited ability to move about in the environment can impair their ability to perform hygiene self care. Medications also may impact the ability of a patient to perform personal hygiene or tolerate personal hygiene. For example, sedation or medications that cause drowsiness, such as analgesics used for pain medication, can limit that patient's ability to safely participate in care. So we have to use these variety of factors to consider limited mobility, such as surgery, weakness, physical injury, and even obesity. The presence of medical devices also impacts our approach to personal hygiene, because the presence of devices such as indwelling catheters, feeding tubes, or IV lines can decrease a patient's ability to perform hygiene, self care activities safely. So, we want to individualize that care, considering the patient's ability to perform the care, to determine the amount of assistance that they need, and to incorporate any type of assistive or safety devices to facilitate that safe personal hygiene care. We want to think about Cognitive impairments, either acute or chronic, such as stroke, brain injury, psychosis, or dementia, because this can very much limit the ability of the patient to perform self care independently. Patients with dementia often forget to attend to their basic hygiene needs. So, with people that have cognitive impairments, they may be unaware that their hygiene and grooming needs, or they may become fearful or agitated during hygiene. We also want to consider developmental stage, such in this picture here. This is a preterm infant, and this infant in its developmental stage. The skin is almost transparent and is very thin. So you'll notice the plastic bag surrounding the infant. And that plastic bag is used to retain heat so the infant doesn't suffer from heat loss. Safe, effective patient centered care takes quite a bit of effort cognitively. So we have to have this into consideration and to modify how we approach personal hygiene for the patient. Here we are back to the clinical judgment cycle and critical thinking. So we need to know that we are integrating nursing knowledge to consider all these different developmental and cultural influences. We sometimes have to think outside the box or think creatively when we approach personal hygiene and helping our patients to be independent. But we always want to be non judgmental and confident in our approach. Oftentimes, we draw on our own personal experiences to help a patient. For example, with Jamie, she does have personal experience with taking care of people that have these types of limitations. And then, of course, relying on our professional standards anytime that we are beginning our interpretation stage and going into planning of care. So I want you to search the internet for professional standards similar to the mobility assessment tool mentioned earlier. See what you find when it comes to impaired skin integrity. All right, here's our first quick check. So you're caring for a non-English speaking male patient. Lot of things to consider there culturally, gender preferences, developmentally. And when you're preparing to assist him with personal hygiene, you should A, B, C, or D. What is most important for this patient at this given time? And the answer is B. When caring for patients from different cultures, we want to learn as much as possible from them and their family about their preferred hygiene practices. So remember, the patient is the center of all of our care. Now, going back to Mrs. Winkler, Jamie's reviewed the knowledge about effects of chronic illness on body image and independence, so she's coming into the situation prepared. And that's a key aspect. So, being prepared and having some understanding of the pathophysiology of any disease process that your patient is might be a factor. And her previous clinical experience has taught her that the patient needs to have an opportunity to determine how the nurses implement nursing care. So she does come from a standpoint of having some experience, and that's a good solid base to come from. So, what ethical standard needs to be applied to allow Mrs. Winkler to make decisions about her care? What do you think? Ethical standard. So, remember in previous weeks we discussed many ethical standards. So, we want to maintain the patient's autonomy, giving the patient choice and maintaining self care and independence. So, we want to encourage Mrs. Winkler to make decisions about how to proceed with her hygiene by engaging her in therapeutic conversation. So, looking at this through the patient's eyes, we assess the patient's expectations about hygiene, their ability, what they can tolerate. Many times we do not assess all body regions routinely before we give hygiene, but we do need to conduct a brief history to determine priority areas. For example, a diabetic, foot care is very important, or a patient who's overweight who has many skin folds, or the patient that's immobilized. Skin can be a factor there as well, especially if they have immobilization devices, where that device can cause friction between the device and the skin. So we plan our care in a relevant fashion and individualize it for the patient. Assessment of a patient's ability to provide hygiene self-care helps you to decide about the type and the amount of hygiene care to provide and how much the patient can be encouraged to participate in care. But when our patients have self care limitations, we may encourage family to help, and we work with the family to design that patient centered care. You will soon be discussing and learning in great detail assessment of a patient in this course and in adult health. For purposes of this class, though, we'll focus upon the objectives and not physical assessment at this given time, although that is always in the back of our mind. Learning the key terms is an important aspect. For example, the definition of edentulous. Once you begin to learn more about assessment, please revisit the tables and boxes specific to common skin conditions. So, back to the definition of edentulous. Edentulous is basically a person that does not have any teeth. We determine a patient's level of cleanliness by observing their appearance of their skin, by being cognizant of any body odors that can indicate inadequate personal hygiene or excessive perspiration caused by fever or pain. We want to inspect less obvious or difficult to reach skin surfaces, such as under skin folds or, for example, the perineum or the groin for redness, moisture, soiling, or debris. We separate the skin folds carefully and observe and palpate. It's important to keep these areas dry, especially with patients who are overweight. Sometimes cornstarch can be used to decrease friction and absorb moisture, but that's individual up to the facility's policies. We want to carefully assess the skin under orthopedic devices or immobilization devices such as braces, splints, casts, and beneath items such as anti embolytic stockings and tape. We want to assess the condition and cleanliness of the perineal and anal areas during hygiene care because this is a factor when patients require toileting assistance. Prolonged contact of urine and feces to the skin, such as in situations of incontinence, can quickly cause the skin to break down. But we have to be sensitive because these areas are private, and our approach to that should very much model the patient's preference and maybe education and helping them to understand why it's important to keep these areas clean. When a patient, for example, has oxygen tubes or nasogastric tubes, sometimes these tubes can cause pressure and friction. Sometimes, if they're mouth breathers, their oral mucosa and lips can become very dry. When they're dehydrated or in malnourished states where they have limited protein or caloric intake, this can also predispose to impaired tissue integrity as that skin becomes thinner, less elastic. The smoothness is lost of the subcutaneous tissue, and wound healing is poor, and skin turgor is impaired from the reduced hydration state. So Jamie learns that Mrs. Winkler likes to have her face and hands washed first, and then her teeth brushed for breakfast. So we all have a routine. that we go about. So we don't go with our routine, we ask the patient what their routine is. So she's determined this, but then she tells Jamie that it is really not important. But Mrs. Winkler says, I'm not going to have breakfast today because my mouth is sore. So that's a clue for us. I took my dentures out yesterday and they hurt my mouth too much. I guess I just can't wear them anymore. So Jamie determines that assisting Mrs. Winkler with her oral care now becomes the priority. So Jamie synthesized all this knowledge, and from her previous clinical experiences, she's starting to notice and interpret the information in planning her care and making those nursing diagnosis problem statements. She wants to be sure she's getting accurate information and incorporates therapeutic communication, which will meet that standard of quality care. So, what are some assessment questions Jamie could ask Mrs. Winkler and other assessment tasks Jamie could perform? Think about this. What care is important this morning? Assessing the condition of Mrs. Winkler's oral cavity would certainly take priority. And assessing her ability to bathe and perform oral hygiene care. This gives an indication of her range of motion and her upper extremity strength. So here are some common diagnoses associated with hygiene. And you'll notice that activity intolerance is one of those problem statements that can be used, along with impaired skin integrity, ineffective health maintenance, risk for infection, and impaired oral mucous membrane. So, knowing what you know now about Mrs. Winkler, I want to challenge you to try to make a 3-part problem statement using that information as related to, as evidenced by. So Mrs. Winkler states she wants to be able to wear her teeth and to feel clean, but she has this mouth pain and sores in her mouth. And when Jamie does her assessment of her oral mucosa, she notices the red sores and patchy white lesions. Her gums and tongue are thick, have a thick coating on them, and some looks like some of her gums or the tissue has been bleeding. And Mrs. Winkler states that she has trouble holding her arms above her waist and trouble holding small things because her muscles are so weak. We want to make sure that we're noticing odors as well. So, as I previously mentioned with personal hygiene, odors such as halitosis, which is a specific bad odor as for the mouth, for the oral mucosas. And Jamie also observed that she was unable to raise her arms above her head and unable to grasp maybe her toothbrush and her hairbrush. So, have you considered the problem statement? What nursing diagnosis problem statement would be appropriate in this case? So, I'm going to give you a hint. Has to do with her impaired oral mucosa membrane. So, what's the related to part of that? Well, she has difficulty performing oral and denture care. And what's your evidence to support that? She has upper extremity weakness. So, in formulating the goals and outcomes, we know we want to partner with the patient and the family, and we want to make these measurable, achievable, and individualized. We set priority based upon assistance required and extent of problem. So, the key for Mrs. Winkler is number one, her oral mucosa is certainly showing assessment signs that would be concerning. And if she cannot wear her teeth, we might be dealing with a situation where she is not able to eat sufficiently, and that can lead to malnutrition. So, working with the healthcare team and in collaboration with her family, we can help to plan her care and hopefully achieve the outcomes that we need to and the patient needs to. So, we're looking at these goals. So, what expected outcomes would you suggest to accompany these goals? We know we have a knowledge deficit, and that's related to her illness. So, Mrs. Winkler can verbalize preventative and routine oral and denture care by the time of discharge. Or maybe Mrs. Winkler will have return of intact oral mucosa within 1 week because that is realistic. It takes time for tissues to repair. Some other things that we might think about is Mrs. Winkler will state the importance of reporting symptoms, including mouth tenderness, discomfort, sores, dry mouth, presence of coating within 2 weeks. She'll describe corrective preventative oral hygiene. Her oral mucosa will be moist and free of thick coating. Her oral cavity will be odor free, and she'll report her mouth feels clean. So, in using that clinical judgment model, we're now implementing or responding to these problems that we have noticed in Mrs. Winkler's care. So, we're using caring to reduce anxiety and promote comfort, and assisting her to perform her hygiene independently as much as we can. This helps with health promotion. So make any instruction relevant based upon your assessment of the patient's knowledge, motivation, preferences, and health beliefs. We want her to adapt to instruction, or we want to adapt that instruction to the patient's own personal bathing, um, their maybe the facilities they have at home or at present, and resources they have available to her. For example, if she were to go home, the family would be a resource in helping her with her personal hygiene. We always want to teach patients to avoid injury. So, what types of injury might occur with personal hygiene? For example, testing the water before bathing. And we want to reinforce infection control practices, such as when Mrs. Winkler removes her dentures, it's best to put them in a container and making sure that they're clean from any food debris when she's soaking them in the container in water. So, health promotion needs to be relevant. We need to adapt the instructions, teach the patient to avoid injury, and reinforce. Hygiene measures vary according to the patient's need and the healthcare setting. The acute care setting is very much different than the home setting, as is the restorative setting, which is what Mrs. Winkler, the type of setting she's in right now. So it's kind of an in between place between the acute care and home. The goal of restorative care is to get the patient back to as much independence as possible. So, if a patient is physically or cognitively impaired, we need to increase the frequency of skin assessment, assessment of oral mucosa, because we want to catch any type of problem before it gets out of control. And people with cognitive impairments do not have that ability, and they face certain challenges and special needs. They often can become very afraid, or they may be simply forgetful. They may refuse, withdraw, or fight even during personal hygiene, such as a bath or a shower. So, we want to ensure that we understand and manage their physical limitations and their aggressive behaviors, using good assessment and communication skills to help them participate as much as they can in their personal hygiene. For example, a patient that might have unmanaged pain, or maybe they're cold in the shower, or maybe frightened, maybe they feel embarrassed, or maybe they feel like they don't have any control of the situation. So we adapt the bathing procedures and the environment to adapt to those needs. So if a patient's in pain, we can administer any type of ordered analgesic 30 minutes before a bath. We want to keep the environment warm, keep the patient's body as warm as possible, regulating the room temperature to be a comfortable level for the patient. We want to help to reduce their fear. For example, in the home, the installation of grab bars or even a shower mat or bath mat or perhaps a sitting stool can help that patient reduce their fear in completing their personal hygiene. Traditionally, baths have been given using soap and water, but we're moving away from that now because what we have discovered is the presence of a biofilm that often forms with the use of bath basins and soap and water. And what this causes is multiple colonies of microorganisms actually attach to the surface, such as in a bath basin, causing this biofilm, which can lead to infection when it's transferred to the patient's skin. And when a patient is chronically ill, they're even at more risk for these type of infections because your immune system is not functioning at its optimum level. So we've many times we have went to in the acute care setting uh, personal hygiene that includes the use of chlorhexidine gluconate solution in place of standard soap and water in the bath basins, and this helps to decrease the bacterial growth in the bath basins and reduces the incidence of a very deadly hospital-acquired infection called methicillin-resistant Staphylococcus aureus, or MRSA. If we have to use a bath basin, we want to be sure that it's air dried completely and to not use the basin for storing supplies, as you often see in the acute care setting. Another option to using the chlorhexidine in a bath basin is to use chlorhexidine impregnated washcloths or throwaway type washcloths. So these are great for broad spectrum microorganism coverage, and actually the antimicrobial activity lasts up to 24 hours after you use these types of washcloths. You don't have to rinse with these washcloths, and they're totally disposable, so there's no laundering involved. A daily bathing with a 2% chlorhexidine impregnated cloth versus a non-antimicrobial washcloth reduces cross-contamination and colonization of multi-drug resistant organisms such as the one I just mentioned, which is MRSA. But we want to be careful with these types of cloths and with this solution because we don't want to be using it above the patient's jawline. It can actually be very irritating and damaging to the eyes and the ears. We use a regular washcloth moistened in warm water for the face. And we don't rinse the chlorhexidine off the other body areas because that would interfere with the antibacterial effects. We also don't want to use chlorhexidine, or we also want to use um, chlorhexidine on superficial wounds, but we want to be very cautious if it's an open or a deep wound, such as pressure injuries. We bathe around the wound with the chlorhexidine, but we don't actually use it within the deep wound or on third or fourth degree burns. So, paying attention to privacy, we close the doors, pull the curtains, try to maintain safety, keeping the side rails up, especially if the patients are unconscious. We know that side rails serve as a restraint, and you do need a healthcare provider's order to do that. But if we're at the bedside, we can do this temporarily for safety. We want to keep the room warm, keep the patient warm, because we know wet skin causes excessive loss of heat through evaporation, and try to control any drafts. We only expose the body part being washed, so keeping everything else covered and only exposing those areas. We want to try to promote independence, encouraging the patient to participate as much as they possibly can. That also helps with range of motion. and building up exercise tolerance. Always enter into a situation where you're performing a skill such as personal hygiene, anticipating everything that you might need. So, coming into the situation prepared. So, do I have a new set of clothing? Do I have all my hygiene products at the bedside, easily available? That is very important for the nurse's duty. If we're taking care of an unconscious patient, we have to recognize the fact that unconscious patients have a reduced or sometimes even absent gag reflex. And what that means is they cannot swallow any secretions that accumulate in their mouth. So we have a pooling of the secretions, and that pooling in the back of the throat can harbor dangerous microorganisms. And if they aspirate it or breathe it into their lungs, this can cause a very deadly pneumonia. So, to provide proper oral hygiene, we keep the mucous membranes moist. We might need to use sectioning to remove any excessive secretions that contribute to those infections, and be cognizant of the gag reflex. So, we're not introducing a bunch of solution into a patient's mouth that is unconscious if they do not have a gag reflex, or even if they have a reduced gag reflex. We want to protect them from choking. Now, current evidence is showing that even the use of chlorhexidine with oral hygiene, especially on ventilator dependent patients, greatly reduces the risk for ventilator associated pneumonia, which is a hospital acquired condition that does not and should not happen. And we want to do everything we can to prevent that. When we're thinking about combing the hair, um, brushing and combing the hair, shampooing, shaving, taking care of mustaches and beard, we can always delegate these activities, including personal hygiene, to the patient care technician. But if we're delegating, we have to make sure that the patient care technician or CNA is aware of certain procedures such as safety, um, and being able to perform the procedure appropriately and efficiently, and always considering different aspects of care such as mobility restrictions. So although we have the overall responsibility, we also have a responsibility when we delegate. Ultimately, it's up to us. Many of our clients have medical devices, eyeglasses, contact lenses, hearing aids. So we want to be aware of being careful when we're removing those. We need to be aware of cushioning and protecting the skin in those high risk areas, such as around the ears and the nose, because any friction that can occur in those areas is a source of potential injury. So we gently cleanse those areas and looking for irritation at least daily, if not more often. So, in thinking about the patient's environment, we always want to maintain room comfort um, in terms of making sure the room is warm, comfortable, that it's safe. Patients and visitors are free to move about. There's no barriers around the bed. There's no clutter on the overbed table. And keeping the room neat and tidy and orderly helps to contribute to that patient's sense of well being. There's nothing like going into a cluttered up room with bed linens everywhere, stuff on the counter, stuff on the bedside table, to make care difficult and make the patient feel have a less of a sense of well being. You never want to put urinals or bedside um, urinals or bedpans on the overbed table, because think about it this way: that's also the table that generally patients eat on. Some common bed positions you need to know as a nursing professional are in your textbook, and, and there's pictures for each one. So I have here in this slide a picture for Trendelenburg position. So Trendelenburg position is head down, feet up, and there are many positions, and each of these positions has unique uses and common uses. For example, the Fowler's position, which is a 45 to 90 degree angle, is very helpful for patients when they're eating. It's very helpful to have them in this position when you're inserting a nasal gastric tube, or maybe suctioning them with a nasal tracheal suction device. This position also helps to promote lung expansion and can ease difficult breathing. So please review and understand these common positions, their description, and their common uses. An interesting fact is many nurses and nursing professionals, PCTs, and students often get Trendelenburg and reverse Trendelenburg confused. Okay, so back to our case study. Some questions to think about for our patient. What interventions are appropriate for restoration of oral health? What is the rationale supporting each intervention? So, some example interventions are removing, cleaning, and not replacing dentures except for meals if you're trying to promote healing because of mild to moderate stomatitis, which is the red, irritated, white patches that the nursing student noted in Mrs. Winkler's mouth. We want to be providing oral care at least twice a day, cleansing for a minimum of 90 seconds with a toothette or a soft bristled toothbrush. We have to be very cognizant of not injuring the oral mucosa further, and especially so if we have a patient that is maybe on a blood anticoagulant, where bleeding can often occur, even with a soft bristle toothbrush. We want to assist the patient with rinsing their mouth four times a day using a bland rinse such as normal saline. This helps to loosen any debris and aids in oral hydration. Sometimes they use sodium bicarbonate solution, which reduces the acidity of oral fluids, discourages any type of yeast colonization or infection. We want to make sure dentures are properly fitted, so we might need to consult with our healthcare provider for that and check fit the dentures. Loose fitting or poorly fitting dentures are very common in denture induced stomatitis, like our patient has. We want to carefully observe the oral mucosa at least twice daily, noticing, are we meeting our goals? Is the oral mucosa improving, or is it worsening? So all of those interventions we have done in our goal, we are constantly assessing and reassessing as we try to help the patient progress towards that goal. So through the patient's eyes, we determine from the patient whether care is being provided in an acceptable manner. So, always going back and using those good active listening, therapeutic communication skills to determine, are we doing a good job for this patient? And are we meeting the outcomes that we need to meet? And if not, we're using education, such as the Teach Back method, to try to reformulate our plan and the interventions we use if those outcomes were not initially met. So, going back to our case study, Jamie asked Miss Winkler about reporting of symptoms, and she states she now knows that her oral discomfort and sores were related to the care of her dentures, and that she will report these symptoms if they reoccur. We can't just assume because Mrs. Winkler wore dentures that she knows all there is to know about taking care of her dentures. It's our responsibility as nurses to teach patients that. So, our achievement of our outcome is shown because Mrs. Winkler is able to participate in prevention of oral problems by reporting those symptoms and indicating a problem. So, Mrs. Winkler lists the steps that she needs to take to prevent the reoccurrence of oral problems. She states, "Now I'm always going to take my teeth out at night so they can soak." And although Mrs. Winkler does not have the ability to perform her own care yet, she is still involved in care because she's making the decision to request that oral and denture care. Jamie should also assess Mrs. Winkler's oral cavity, and when she does this, she notices that the lesions are no longer present. The oral mucosa is pink, moist, not swollen. There's no odor in the oral cavity, and there's no coating on the oral surfaces. This tells the nursing student Jamie that the inflammation and infection that had been in her mouth had been resolved. So we have met our goal. So, some final thoughts: safety guidelines for nursing skills. We always want to identify the patient with two identifiers. So, looking at the patient's bracelet, asking them their name and birth date as we are looking at the bracelet. We move from the cleanest to the less clean areas. So, cleanest to the less clean. We use clean gloves when we contact non-intact skin, mucous membranes, secretions, excretions, or blood. So, in caring for Mrs. Winkler's oral mucosa, we would always wear gloves. We test the water for a temperature. It's not too hot, not too cold. We use principles of body mechanics and safe patient handling, such as putting the bed in the up position while we're at the bedside performing, say, a bedside bath. And we give proper direction to others when delegating. Okay, well, that is the chapter on hygiene, and I will see you soon. Thank you very much.